Hello everyone and welcome to the panel discussion BRCA Genes and Beyond. This Breast Cancer Awareness Month, we are here to discuss the genetic implications on breast cancer treatment, prevention and survival. A lot of you may know breast cancer comprises 30% of all cancers diagnosed in India, out of which around 8 to 12% comprise hereditary breast cancers. That means it can get passed on from one generation to another. These genetic breast cancers or hereditary breast cancers can have an implication on how the treatment is planned by the doctors. That requires constant communication between the treating doctors, the molecular oncologists and the patient, and facilitating all of this, a genetic counselor. At Shankara Cancer Hospitals, Bangalore, we have an interdisciplinary team handling all of this and ensuring that our patients get the best care. Today, we have Dr. Sandhya Appachu, medical oncologist, Dr. Aruna Korlimarla, molecular oncologist, Dr. Lohitha Krishna, breast oncoplastic surgeon, and Niby Jacob, genetic counselor. Let us begin this discussion in trying to understand what are the preventive factors for breast cancers and what are the genetic factors, risk factors for breast cancer. Or let me rephrase that. What are the risk factors in general for a person to develop breast cancer? And specifically, what are the genetic risk factors that one may have that would increase their risk of developing breast cancer?
Coming to how this breast cancer is caused, so what is the driver force for breast cancer? If we can come to know about that, we can easily delineate the causes for breast cancer. So most of the breast cancers, we have different types of breast cancers, but most of the common ones, the hormone positive breast cancers, are basically due to a prolonged hormone stimulation in the body. So what are the situations that cause such prolonged hormone exposure in the body? One is early menarche, that is like a female or a young child attaining menarche at an early age. We all know now that with changed lifestyles, obesity coming up in children, children are attaining menarche at an age of around 9 to 10 years. So once they attain the menarche at such an early age, they have prolonged estrogen production from the ovaries. This is one of the contributing factors. Second is late menopause. That is if a patient, a female has a prolonged duration of menstrual cycles. Like normally the age for menopause is usually between 50 to 55 years. So if it goes to 60 years, there is a long-term estrogen exposure in the body as well. So this late menopause is one of the risk factors. Then nulliparity. So there are situations where couples do not want to conceive or delay their childbirth. So this whenever there is a childbirth or whenever there is a woman conceives or lactates, there is a pause in the ovaries of producing these hormones. So this is what is protective for breast cancer. So when that is lost, that is when a woman does not bear a child in her lifetime, or it is a delayed childbirth, like beyond 30 to 32 years of age, this is when they are more prone to breast cancer. So the fourth one is obviously the lifestyle changes. Obesity is one of the driver factors. We all know that one of the hormone production is also from the adipose tissue, that is the fat cells. So this also can cause breast cancer in the long run. Then external use of hormone supplements for various causes. It can be some kind of contraceptives, or it can be hormone replacement therapy for certain symptoms where a physician recommends to a woman in her menopausal status where she has a lot of symptoms due to menopause. These can also be a driver for breast cancers. And yes, as Dr. Sanchita was rightly telling, this is something like phenotype. So these are all whatever we called as a causative factor. So if there is a genetic risk, a genotype, okay, either the patient has a hereditary backup where there are familial causes for breast cancer, or she's a carrier of one of the genes which can be a risk for breast cancers, then these phenotype can transform into an early onset for cancers in this type of female. So when a patient comes for such genetic testing, who are the patients whom we usually think that there can be hereditary cause for a cancer is a young age female. So young, whenever we call, it is any patient who is less than 50 years of age. So any patient who comes with a diagnosis of breast cancer at less than 50 years of age calls for a hereditary cancer testing. Then there are certain particular varieties of breast cancer which are commonly associated with hereditary causes. One of them is a triple negative breast cancer. So triple negative breast cancers at any age call for genetic testing. So and any patient who has a male family member affected with breast cancer, as multiple family members affected with breast, ovarian cancer, pancreatic cancer, prostate cancer in males. So all these females rightly call for testing for genetic cancers. Again, our genetic counselor is the one who will get involved in putting up a pedigree chart and seeing what risk they fall in and do they really call for such testing. So that is the next level where we take their consultation. So these are the known factors.
For me to clarify to the audience that you don't suggest genetic testing for everyone, but only for women under 50 who are diagnosed with breast cancer, or of any age group who have been diagnosed with triple negative breast cancers or have other cancer groups, cancers in the family that within their relatives. I'd like to ask the next question to Dr. Lohitha. How would this have implications on the surgeries or the treatment? So we know that the first choice of treatment would be surgeries. So if they come to you with genetic test, and how would that change your treatment plan? How would that affect it?
As Dr. Sanchita has asked, how would it change? So one is, when do we ask for this testing? So some of the times this testing is right ahead told to the patient as we are working up her case, when we are doing her workup, she's newly walked into the OPD, we see the IHC report, and when it turns out to be a triple negative, or if she's of a younger age group, asking her family tree, that is the time when we do suggest them to undergo this genetic testing. So once this is done and they come to us with the report, so the duration of time until the report is out is somewhere between, say, 15 days to 21 days. So there are cases where we do an upfront surgery. There are some cases where the patient first starts ahead with neoadjuvant chemotherapy and then comes. So in patients who start ahead with neoadjuvant chemotherapy and then they come to us next with the genetic counseling report, that time the patients who have been tested positive, we do have a window to talk to them about their surgical options which are there. So we can do something called as risk reducing surgeries in them. So these patients who have developed a cancer and have undergone testing, not only is that they've already been diagnosed with this, they have a risk of developing other malignancies also in their lifetime. So looking at their age and those risk factors, we do advise them some risk reducing surgeries like a contralateral mastectomy or a risk reducing salpingo oophorectomy. These are the common things that we do. And as during her chemotherapy or post her chemotherapy in the adjuvant setting, there are some drugs which we can add to the treatment for better outcomes in these patients.
What are the so when you said that when they come in to you and you, after looking at the IHC report, you'd suggest a genetic test. So I'd like Dr. Aruna to give us some information about what are the different types of genetic tests that are available. And just before you begin, if our viewers have any doubts about what an IHC test is, we have done a video about it before and it will be linked up here and you can check that video and then move on so that you'll get some information about what an IHC is, and that will help you understand this better.
So genetic testing actually has undergone a whole spectrum of changes in the past decade. It has now become very affordable and very easy to do in a lab. And we have a basic test which, when we know there is a very strong family history, of course, there are two genes that are mainly linked with being causal for breast cancer. That is what everyone is very familiar with, the BRCA1 and BRCA2, most popularly known as BRCA genes. So if the family member, first or second degree relative, is a carrier of a BRCA mutation. She may have cancer, she may not have cancer. Still, this person becomes eligible for testing. So in those patients where we know that the lineage is with the inheritance of probability of the BRCA gene inheritance, we can do the basic panel and just look for BRCA1 and BRCA2. And the penetration of the mutations, by that I mean the possibility of this person developing cancer due to that mutation is very high. Therefore, we can confidently test the basic panel. But research has now revealed, and we have a greater understanding of the biology of mutations which are present in multiple other genes in what we call as the HRR pathway, which could still be causal. And we know a lot more about the behavior of these cancers. Therefore, in unknown cases where we don't have information from the family, we would recommend for an extended panel testing where we come to know if there are mutations present on all these other BRCA and the related genes, which will become significant in the biology of the disease. Therefore, it becomes easier for a surgeon and a medical oncologist to counsel the patient and take decisions accordingly. Of course, there are a lot of ethical considerations to testing because the person who has to undergo testing has to be willing and in full knowledge of the fact that, you know, we are going to unwind their DNA and look at these mutations. And that's where the interaction with the genetic counselor is very important, and patients who undergo testing have to speak to the counselor both before and after the test. I'm sure Niby will take this forward, the role of a genetic counselor in this scenario.
Dr. Aruna, when we speak about tests in a cancer hospital, most of our patients know of two types of tests. One is where the tumor itself is tested versus giving their blood for testing. So can you elaborate a little bit on the roles of these two tissues in genetic testing?
Sure, that's a very interesting question that needs to be explained. Testing the tumor tissue is what we call as a somatic testing. It is testing for an event that has happened in a specific group of cells only that are in that cancer. So that is what we call as somatic, versus a germline event is something that a variation that is present in each and every cell in the body. Therefore, blood cells are representative of all the cells. Therefore, we take the blood sample from the patient to test for this kind of a test, and that's what we call as a germline test. Whereas a somatic test, we would be interrogating only the tumor cells.
So there is a lot of talk about genetic counseling and genetic counselors, but we would like to get some clarity about what a genetic counselor does and how is it that you approach, what is the approach that you take with each patient in guiding them through this process?
This is a million-dollar question that everybody has. What does a genetic counselor do? A genetic counseling process is essentially a two-way communication between the patient and the genetic counselor more than anything else. The primary role of a genetic counselor is that of a patient advocate. So a genetic counselor liaises between the surgical oncologist, medical oncologist, the lab, as well as the patients to give them a complete picture and understanding as to what is going on. So there are two situations in which I see families or patients. Usually it's pre-test or post-test. So pre-test is when they are considering getting a genetic test done, but they want to understand about the implications of undergoing a genetic test report. So the first and foremost what we do is take a 3-generation family history. This is very, very important for us to assess whether just a BRCA1 or 2 is required for testing, or should we explore and include other genes as well. This completely depends on the family history, the ages, diagnosis of various members in the family, what kinds of cancers were they diagnosed with. So we try and get as accurate information as possible with respect to the family history. Then we interpret information, medical information, and explain to them and educate them about what do these risk factors mean, what are genes, what is inherited cancers, and we also give them the space and time to ask any questions that they might have about genetic testing process itself. If they're unsure, there might be a lot of anxiety, especially where there are families with extended family histories. There's a lot of anxiety, there's a lot of high perception of risk by default. So a lot of the times it might be helping them unlearn a lot of Google facts and information that they have on, and also be there as a support system for families. There's a lot of underlying psychological issues as well that play into their decision making, and what really helps them figure out and make a decision that is important for them, for family members as well. So I think the three key areas that a genetic counselor plays a role is in educating them, interpreting what these test results, what their own medical history means for them, as well as providing that support system. Because going through a journey, through a diagnosis, going through treatment is extremely difficult. And they also need to have that space to be able to just ask questions as they might have. So that is essentially what a genetic counselor does. And even when we see patients in a post-test setting where they've already undergone a genetic test and they come to us with the genetic test report, we essentially interpret whether it's a positive report, whether there is an uncertain significance, a variant of uncertain significance picked up, or even if it's a negative report, but yet there is a significant family history as well as personal history. So all of that needs to be interpreted, and what we do is have a personalized approach to every patient. It's not a blanket approach to everyone. And so I then talk to the medical oncologist, surgical oncologist, and the molecular department to figure out what is the best way forward for that patient as well as the family.
Thank you. So from what I understand, a lot of patients actually do require genetic testing, but do you see as many people come forward and get the genetic testing done? Do you have any instances, ma'am, where you have suggested genetic testing, but they've not been able to go through with it? And if Ms. Niby can actually take it forward and explain to us what are the barriers that you generally see, at least during the pre-test or post-test, that what are the barriers to genetic testing that you face?
So when a patient comes, as Ms. Niby rightly pointed out, there are a lot of things that they're going through. At first, the diagnosis in itself, then we start digging into their history and then telling, yes, it might be a gene that is running in your family and that might have caused you this risk. So they're really alarmed. So one of the alarm that causes, and I have instances where, patients actually break down telling that I shouldn't be infecting my other family members. When we try to tell them, no, this is not an infection. This is something which might be there hidden in your family. You have just kind of manifested with the cancer, and there may be so many other family members, that can be rightly detected, screened at an early age. You have been diagnosed. We could screen them at an early age and detect it, at an early stage. That's what we try to convince them with. Second thing is, most of the young women who come to us are married, they have children, so their next concern is what is the risk to my children. So that is when we also tell them that we first test on you, and then if it is positive, then we test on your siblings and children. It doesn't mean that it is a 100% thing that your children will get affected. It's a 50% chance, so we need to test and see. So science makes it easy. You need to take help of science, get the information right, talk to our counselors, discuss with us, and then do the right move. Third thing is, in a family wherein there are multiple family members affected, one of the concerns they have is if this causes a marital discord or something like, first of all, the women themselves feel the diagnosis is a burden to the family, because they've almost always the women have been giving. They've never learned to take from something. So the time they are sick and they have to take rest, and they're dependent on their family members to take care of them medically or physically. This is one of the things that revealing to the family members. How can it be revealed to the family members? How will they take it? What are they going to tell? So the fourth scenario is in a carrier. Like we detect elderly lady with cancer. There is a particular type. We test for gene. She comes to be a genetic positive. Then we test their family members who are still not manifested with the disease. They are called as carriers. They still have the gene with them. It is not still caused any kind of events in their lifetime, but yes, it can cause. So then we need to counsel those family members as well whom we test. What is that they need to do, screening wise, detection wise, any prophylactic surgeries, any kind of chemo prevention, or any medicines they can take to prevent such cancers. All these questions come. So from here I would lead the mic to Ms Niby. She will actually tell more barriers in her clinical practice which she faces when we send those patients to her.
I think one of the most prominent reasons why patients or family members may not actually go through with the tests is the cost factor. So cost is definitely a factor. And the other problem is already there's a high cost associated with just the diagnosis and treatment. And so when the cost of testing adds on to it, a lot of patients feel that this is not something that is absolutely necessary right now. And so they often delay testing to a later point of time. Another factor is insurance. Most insurances do not cover the cost of testing. The cost of test is covered out of pocket by the patient. But even then, there are instances where we try and encourage the family to think about testing, especially where there might be implications in terms of risk management. So over to you, Dr. Lohitha.
I would definitely shed more light about risk-reducing surgeries, and surveillance also a little bit. So once a patient comes up saying that, and they are known to be carriers of these mutations, then we definitely recommend them. They should have breast cancer awareness from the age of 18, and clinical examination starts from the age of say 20. Self-breast examination starts from the age of 20. We start doing breast MRIs and mammograms yearly from the age of 25 is for MRIs and mammograms also. Even though high dense breasts, we still start from the age of 30. We take it up till age of 75 years. So this is done annually. And next comes your risk-reducing surgeries. So in carriers, definitely the options are discussed with them about these risk-reducing surgeries. That is prophylactic bilateral mastectomy. As you all know about what we call as the Angelina Jolie effect, when she got a diagnosis that she has a strong family history, that there are a lot of patients, lot of her mother and everyone, she was a carrier. She did not develop the disease, but she went ahead and got a prophylactic surgery done so that she doesn't have to face the disease. So this is what we call as prophylactic surgeries. Before the disease develops, we go ahead and stop it from occurring. So this is something is prophylactic bilateral mastectomy is what we advise to patients, and at the same time they can undergo immediate breast reconstruction also for a good cosmetic outcome, as well as we advise a bilateral salpingo oophorectomy. So for BRCA1 carriers, we advise it between 35 to 40 years of age, and for BRCA2 patients, they can get it between 40 to 50 years of age. So this is an ideal time, where they can preserve their ovaries, finish their families, and then undergo the procedure. And secondly, they do not have to have a menopause early, so they can preserve their ovaries, have a good effect, and then we can do a salpingo oophorectomy. So these can be done either as a single time undergoing everything, or as staged procedures also, once we talk to the patient and they understand these decisions like that. When the patient is not very keen on risk reducing surgery, she is under regular surveillance with her breast MRIs and mammograms. Now, patient who has already developed the disease and she comes up with this positive report, definitely that is when we include these mastectomies. So, patient who has this has tested with a mutation, there's no contraindication, absolute contraindication against a breast conservation surgery, but definitely we do have a shared decision making with the patient, explaining her to that okay, you are undergoing a breast conservation surgery, there is a risk of developing even in the opposite breast or same breast also anytime, and then according to that decision between the patient, and once she understands her risk and she's willing to, it is done. So in the same time we can advise them to undergo a salpingo-oophorectomy also. But then again, there are many things which play in this, looking at her hormone type and time and all that, and it is advised either in the same time or once she completes her treatment also. There are days when she can undergo this. So but understanding about the surgical implications is also very important, and it is always a shared decision making where we talk, and then Miss Niby, the genetic counselor, also comes in, the medical oncologist also, together. Once we tell and explain the patient about the risk, the decision, it's easier for her to make the decision with her and with other family members into account also.
Thank you, Dr. Lohitha. Now, these implications that you've all mentioned is when we have a clear genetic test report. Sometimes we often see that there is a variant of uncertain significance. I'd like Dr. Aruna to throw some light on that, and how do you approach such cases?
Yeah, the variants of unknown significance are quite a challenge, because while it only means that it is somewhat in between a positive and a negative report. Patients or even doctors understand positive and negative, but this variant of unknown significance is not negative. It only means that we don't have sufficient functional evidence that this variant could be causal. So it creates a lot of anxiety for the patient and the treating physician as well as the counselor, because we don't know the significance. However, there are a lot of bioinformatic tools now which have gotten better at classifying the variants of unknown significance. We take into account the segregation history of the patient, that is, who in the family has cancer, how many people have cancer, how many are carriers, have disease, don't have disease. And in the background of all this information, and with the help of these bioinformatic tools which are now very advanced, it is possible to reclassify the variant of unknown significance, or take the VUS and actually correlate it with that particular case, and then accordingly make a clinical decision. So while VUS is an uncertain variant, however, it is not a negative report. It does not mean that the risk does not exist. It also does not mean that the risk is as high as a patient who has a positive report.
Thank you, Dr. Aruna. So when we speak about Breast Cancer Awareness Month, the general assumption is that it is only female focused. But we do see some males with breast cancer. And what are the differences in genetic testing or implications? Okay, let me rephrase that. So do men get breast cancer? One. And what are the genetic tests? Is it the same? Are the same genetic tests that you would do? And if can men be carriers of the BRCA genes?
So I would like to answer this question in part, and then I think Niby will take over for the rest of the question. So yes, male can develop breast cancers because they do carry the organ. So the one thing that is striking with male breast cancer is, in a female, the breast cancer can be associated with various causes, which I told you before. Before we used to tell cancer is a disease of age. So elderly women used to get cancer, and now we are seeing youngsters. But in men, well, the single point of focus is whenever a male member in the family gets affected by breast cancer, that means to say that is hereditary. It has a very high chance that the patient is affected because of a gene that is running in the family, and also calls for a screening of all the family members. The second thing, when we talk about male breast cancers, they are obviously detected at an early stage because the breast tissue is quite small, and they notice some kind of discomfort or a lump or a ulcer or a nipple discharge or something like that, and they immediately come to attention. So that way, and the treatment per se for male breast cancers doesn't differ much. It is again surgery, chemotherapy, radiation, hormonal therapy, all those which encompass female breast cancers as well. But yes, the screening, the penetration, and the carrier risk, I think Niby will take over.
So especially when we're talking about male breast cancers, we are looking at primarily the BRCA gene, as well as there are other genes also that have been implicated in male breast cancers. So like Dr. Sandhya mentioned, whenever we see, even if there's no family history, there is just one male in the family who presents with male breast cancer, definitely is a candidate for genetic testing. And we consider a multi-gene panel testing here because it's not just the BRCA gene, but also genes like PALB2 that are implicated in members of families and where there is a history of male breast cancers. Although the risk is not as high for males who carry BRCA genes or any of the genes as women who carry BRCA genes or any of the other high-risk genes, it is still important because this information is relevant for other family members. It can be siblings, it can be the children as well. So especially most of these genes can be passed down, so there can be a 50% chance that it can be passed down to the children or the sibling might also carry it. So even in the absence of a family history, if we find that there is a male presenting with breast cancer, it's important to talk to them about the option of genetic testing.
When we go into the field for cancer screening, we often ask women if they have a family history of cancer. And one of the things that we have to explain to is, your blood relatives. And women often say that nobody in my family has cancer, but my husband's family, his sister or his mother had, say, breast cancer. And I have 2 daughters. Now, should I be worried? What would how do we take that forward? What do we tell them?
So this is a great example. I think we've had many of these cases, but I'll just talk about one of the cases. There was a 43-year-old woman who was diagnosed with breast cancer and came to see me for post-test genetic counseling, and we also found that she had a family history. So by family history, her younger sister was also diagnosed with breast cancer the previous year, and her father's sister was diagnosed with breast cancer in the 70s, unfortunately passed away. So her question was, my mother is healthy and the mother's side of the family is healthy, how come I have gotten it, my sister has gotten it? So one thing that we need to keep in mind is breast cancer does not discriminate. It can come down from father's side of the family or mother's side of the family. So especially when there is a history, even if it is on the father's side of the family, a father, sister, father is healthy, there still could be a risk. And when we do a risk assessment and when we are trying to look at candidates for genetic testing in the family to offer them risk screening measures, we look at where the family history comes from. In South India, particularly, consanguinity, that is marriage between relatives, is fairly common. So it can be first cousins who get married, uncle, nieces who get married. So in such cases of families, it is very important to assess and also figure out how are they related and what is the relationship, so that we'll be able to figure out who are the people who could potentially be at risk and also identify people who are the best members to get tested. So as Dr. Lohitha and Dr. Sandhya mentioned earlier, the person who's diagnosed with breast cancer is always the best person to get tested first, because it's easier for us to clinically correlate what we find in a genetic test report. And like Dr. Aruna mentioned earlier about variants of uncertain significance, a lot of the cases we also find variants of uncertain significance in such families. And one of the way that we can clinically provide more evidence is if we test other affected family members. So it's very important to draw out a proper family history and assess who could be the members at risk, who are the people who are diagnosed, and perhaps maybe better candidates for what we call cascade testing, especially in cases where we pick up variants of uncertain significance.
If a BRCA carrier comes to you and says that she does not want the risk reduction surgeries, what are the other options that she has?
when the carrier says she is not very keen on risk reduction surgeries, then of course we have breast MRIs and mammograms which are done yearly from the age of 25 to 75 years, and we insist that they follow self breast examination and even come for a clinical breast examination 6 monthly, 12 monthly and so on. So for examination and screening of the breast, there are definitely brilliant tools, the breast MRIs and the mammograms, which pick up the lesion very, very early on. But unfortunately, for screening of the ovaries, as you know, these patients are more prone for breast and ovarian cancers. So for ovarian cancers, we do not have such brilliant screening tools. Even the transvaginal scans or the CA125 tumor marker testings may not, pick up the cancer early. So in these patients, we really insist that they complete their family and undergo removal of their ovaries and tubes. So this way they are really going to reduce their risk from this ovarian cancer. And if she is keen, the breast, we can still continue screening her. And again, a shared decision where you have to explain them their risks and they are going to take this up forward.
Can we walk through the journey of a patient, a BRCA positive patient, what she'll be facing? So if you have a woman coming to you with a lump in her breast, what would be your role and what would be Sandhya ma'am's role? And ma'am, what are the tests that you would do? And to summarize, how you would help the lady navigate through her process.
First, a patient walks in with a lump and we are evaluating her further to know about what type of lump she has. We do a biopsy, we know what type it is, and we do some metastatic workup, make sure we know whether it has spread to other parts or no. And once we have all these reports, giving her age, family history and all these things into consideration, we do advise them saying, okay, you are a candidate for this genetic testing and you are recommended to undergo this test. So either some women do undergo the testing right at the beginning, some because of some financial implications, they may say, okay, first let me finish my treatment and then I'll be undergoing the testing. So as they go on with their chemotherapy or during their chemotherapy cycles, then again, our medical oncologist also has a conversation with them equally saying, the benefits of testing and what does it mean, how the treatment plan may change once the gene comes positive. And based on that, the decision is
the role of a medical oncologist when a woman gets diagnosed, as Dr. Lohitha rightly pointed out. You assess their risk, their age, and then tell them, yes, you're a candidate for genetic testing. How does it help a medical oncologist? So in planning the treatment, especially, there are certain chemotherapies which are more effective in a patient who is BRCA positive. So we can incorporate such regimens in their treatment plan so that we get a very good control of the disease, and the surgeon gets an easier job done when they can operate on her. The second thing is we also have certain oral tablets which have come in, which are targeted therapies for patients who are genetically positive. So these are given in high-risk women, again the BRCA positive women who do not respond to a conventional chemotherapy. They have disease that is left behind and which are removed by surgery. And then to prevent the recurrences, we give such maintenance oral tablets for at least a year or so in breast cancer. They are also available for ovarian cancers also. So these are all strategies. The second way is, this is for a patient. So you have a carrier. So the family member comes, the treatment is done. So there is an attender whom we also test a mutation-specific test and comes positive. So it's a carrier. So as Dr. Lohitha mentioned, we have measures for screening for them. Anything else do you have? Like the patient doesn't want to remove her breast, so it's like she's not okay with a prophylactic removal of the breast. Yes, you have the screening measures also. So whenever we talk about screening, it is an early pickup. So your organ is still there. So you have a chance of getting detected early. So is it something that you can totally get this thing that you can prevent it at all? Yes, you can. There are certain chemo prevention measures. You can give some hormonal pills. So we have tablets in the market called called tamoxifen, raloxifene. There are drugs called exemestane. So these are the drugs which we prefer. In scientific measures, we have to risk stratify them. There are various risk scores that we have, like a Gale's index or something like that, where we tell what is the lifetime risk for this patient. So if the patient is young, less than 50 years of age, and the risk is moderate to high, these are the carriers who will benefit from such chemoprevention. Usually these tablets are given for a period of 5 years. There are benefits of extended use of these tablets also, but again it's in discussion with the physician. There are certain mild risks involved with this medication, so we need to really sit across with them, discuss screening versus surgery versus chemoprevention, and then take a call and monitor them as well when they're on this treatment.
Basically, we assess what is the test that we have to offer to this patient. We have, like I said earlier, we have a multi-gene panel, we have the specific BRCA panel, but we now know that the risk extends to other members of the genes like PALB2, CHEK and ATM, and they all are also significant in the biology of the tumor. Therefore, we decide whether the patient has to be on the multi-gene testing panel or the very basic panel that only looks at BRCA, depending on what history is known. And then we adequately counsel the patient whether it doesn't matter whether the report is negative or positive. They both have to be counseled, and we strongly advocate that they meet the genetic counselor who systematically takes their history and explains to them the risk even if the report is negative. So the next step for the patient is to actually go and meet the counselor even before the testing and also after the test.
As a genetic counselor, I mentioned about both scenarios, pre-test and post-test, but I would say genetic counseling is also for anyone who's just anxious about their own risk of developing breast cancer with or without family history. So meeting a genetic counselor does not necessarily mean that they definitely have to undergo genetic testing. A lot of the times we assess also the mental state of the patient, where they are at. Are they, do I feel like they have signs of depression? And if they do have signs of depression, then maybe it's better to defer the test at that point rather than to get the test at that point. So I then immediately ring up the referring doctor and also keep them informed that I think, these are the signs and symptoms that the patient has. Google has either the best case or the worst case scenarios. So with or without a family history, and if you're just looking at trying to get additional information, talk to a genetic counselor who will assess the risk and say also which test is recommended. And a definite no, I think, from all of us is over-the-counter genetic tests, direct-to-consumer genetic tests that one can just order online, because these are not clinical grade tests. So if you're considering getting a genetic test done or you just want more information, I guess always contact a genetic counselor, talk to a genetic counselor. So my role is essentially talking to both the surgical and the medical oncologist and ensuring which state is the patient at and, the family members are at. Is there any conflict that I see in the family? Are there any ethical issues that I see apart from just the costing factors, etc., just to make sure that all of us are on the same page with respect to management of the case.
To summarize, to put the patient at first, the patient's needs first, and even if you're not a patient yet, if there is a family history and if a person is a carrier for a gene, there is a lot of that work that goes in from different sets of expertise, and to bring it all together in one place is what we wanted to do today and what we do at Shankara. So we would, if you have any doubts about genetic testing or the role of genetic testing and how it can impact your treatment or impact your outcomes, then please do meet any of your care team, and they'll be able to guide you to the others and get in touch and work together towards giving you the best outcome. And if you have any doubts, please feel free to contact us on any of the social media platforms or leave us a comment and we'll guide you through to your expert. Thank you.